am Madhurima Datta, Zoology and Biology educational content creator. Now's content for class 12, CBSE, ICSE, all boards and also Neet aspirant students. Chapter 3, Reproductive Health, Unit 1, Reproduction, and today I will discuss about the process of tubectomy. Definition of the tubectomy: a permanent surgical method of contraception, that is sterilization, performed in females to prevent future pregnancies. Category: that is terminal or permanent contraceptive method. Procedure: a small portion of both fallopian tubes, oviducts, is removed or tied up. Access is gained via a small incision in the abdomen or through the vagina. Next, surgical techniques and methods. Depending on the clinical scenario, surgeons use different approaches to access and block the fallopian tubes. Surgical approaches: first is mini laparotomy, that is a small incision less than centimeter is made in the lower abdomen or just below and the navel, that is postpartum. Most common method is standard hospital settings. Next, laparoscopic tubectomy. A laparoscopic, that is thin camera tube and micro instruments are inserted through minor punctures. It allows faster recovery and minimal scarring. Next, vaginal approach or colpotomy, that is incision made through the posterior vaginal wall, rarely used due to higher infection risk. First, methods of occlusion or blocking the tubes, that is ligation and excision, that is Pomeroy technique. A loop of the fallopian tube is lifted, tied with a suture, and the top segment is cut off. As the sutures dissolves, the two ends separate naturally. Next, cauterizations or electrocautery, that is electrical currents burns and seals a section of the tube. Next, mechanical occlusions. Tubes are closed off using fleshy clips, Hulka clips or bands, that is fallope rings, without cutting the tissue. Next, mechanism of action: blocks gamete transport. It prevents the secondary oocytes released by the ovary from the meeting the sperm in the fallopian tube. Next, inhibits fertilization, since the site of fertilization, that is ampulla, is blocked and fertilization cannot occur. Next, significance of the tubectomy. First, hormone production and ovulation. Tubectomy does not stop ovulation, menstruation or female sex hormone production, that is estrogen, progesterone, and ovaries remain intact and functional. Released eggs simply degenerate and get reabsorbed by phagocytosis. Next, reversibility. Its reversibility is very poor, that is practically irreversible. Next, STI protection. Tubectomy provides zero protection against sexual transmitted infection or STIs. Next, effectiveness. Has an extremely low failure rate, nearly 100% effective. Next, fate of the unfertilized ovum and physiology. First, hormonal axis untouched. The hypothalamus pituitary ovarian axis operates normally. FSH and LH continue to trigger follicle maturation and ovulation. Next, estrogen and progesterone secreted into blood vessels surrounding the ovaries as usual, and secondary sexual characters, that is libido and menstrual cycle, remains unaffected. And menstruation, the uterine lining shades are normal during each cycle because it responds directly to systemic blood levels of estrogen and progesterone. Next, side effects of tubectomy. First is short-term side effects, that is first 1 to 7 days. Most women experience temporary discomfort following surgery as the body recovers. First is abdominal cramping and pelvic pain, similar to menstrual cramps caused by surgical manipulation of the fallopian tubes. Next, shoulder tip pain. Specific to laparoscopic tubectomy, carbon dioxide, that is CO2 gas, used to inflate the abdomen during surgery can irritate the phrenic nerves and causing referred pain in the shoulders for 24 to 72 hours. Next, incision discomfort and swelling, soreness, mild redness or brushing around the navel or lower abdomen. Next, spotting or mild vaginal bleeding, light bleeding for a few days to a week that is post-produce is common. Next, anesthesia effects, mild nausea, dizziness or a sore throat, that is if a breathing tube was used under general anesthesia. Next, surgical risk and rare complications. Though uncommon potential surgical complications include infections, bleeding hematoma, damage to adjacent organs and anesthesia complication. Infection, wound infection at the incision site or internal pelvic infection, bleeding and hematoma, internal bleeding in the abdominal cavity or localized bleeding around the wound. Next, damage to adjacent organ, that is rare injury to the bladder, intestines or nearby blood vessels during trocar or instrument insertion. Next, anesthesia complication, that is adverse allergic or respiratory reaction. Now the topic has ended. For all video of class 12 and Neet, please subscribe my YouTube channel Biogenesis by Madhurima and follow my Facebook account Madhurima Datta.